Excellencies, distinguished delegates and panelists, ladies and gentlemen, good evening. Thank you for coming to this afternoon side event entitled Best Practices for Maternal Health Care in Africa, which the Permanent Observer Mission of the Holy See is sponsoring, along with the Society for the Protection of Unborn Children, Mater Care International, Culture of Life Africa, Real Women of Canada, and the Campaign Life Coalition. The theme of the 60th session of the Commission on the Status of Women is Women's Empowerment and the Link to Sustainable Development. One of the most important ways that the international community must help unleash the power of women is through genuine support for women who are mothers. The Universal Declaration of Human Rights affirms that motherhood and childhood are entitled to special care and assistance. But in some circles, the unique value and dignity of motherhood and the essential contributions mothers give to sustainable development through their heroic dedication in raising the next generation is insufficiently acknowledged, appreciated, and advanced. One of the most common forms of discrimination among women today happens, especially in labor situations, with regard to the exercise of their maternity. Sometimes, motherhood is even seen as an antiquated and unwholesome and economically disadvantaged model of a woman's life. True respect for woman, however, starts with accepting, indeed reverencing her according to all aspects of her humanity. It involves creating the conditions for her to fully develop according to what Pope Francis and his predecessors termed as feminine genius. This expression highlights women's special wisdom in caring for the intrinsic dignity of everyone, in nurturing life, and in developing others' gifts. When women are given the opportunity to thrive in full participation for all their talents and potential, like in peace building and peacemaking and mediation, the whole of society develops and benefits. All people need to appreciate better the fullness, the full greatness of woman, which include not just the gifts she shares in common with man, which there are many, but also the unique gifts that pertain to her as woman, like her capacity for motherhood. Understood not just as a reproductive act, but also as an enriching spiritual, educational, and affective experience. We all need to recognize the greater burdens placed on women in motherhood and family life, and to rise up in solidarity to help women meet those challenges. Even though parenthood belongs to men as much as to women, parenthood obviously taxes much more the women. Everyone in society should be aware of this and show not just particular gratitude and esteem, but assist women in every way possible. Humanity ultimately owes its survival to the choice women make, not just to welcome children, but to raise them to be virtuous and authentically human, to foster their personal identity and develop positive social bonds. None of us here would be existing if it were not for our mother's loving choice to welcome us and to provide so much of herself in giving us growth and providing for our needs. One area of the world where the gift of motherhood is still deeply esteemed and appreciated as a society as a whole is Africa. Pope Francis, as you know, visited Africa, visited Kenya, Uganda, and the Central African Republic last November. And among the things he affirmed is the importance of the family and certainly the role of the mother in strengthening the family. So in the United States, it is said, statistics say that more than 80% of the health needs of a family is provided for by the mother. So we could just imagine how important the role of the mother is, not only in her own health, but also in the overall health of the family. And I'm sure in some other countries, it's even more than 80% or even more than 90%. Today, we will hear from three speakers we have here who have dedicated themselves in a special way to defending, praising, and advocating for mothers and children. We will hear first Dr. Robert Wally, the founder and executive director of Mater Care International, a global association of obstetricians, gynecologists, midwives, and general practitioners dedicated to reducing the high rates of maternal mortality and morbidity throughout the world. Mater Care is presently doing work in Ghana, Sierra Leone, and Rwanda, and in other places in the world. For 15 years, Dr. Wally also served as a consultant of the Pontifical Council for the Pastoral Care of Health in the Vatican. And I must add that I met Dr. Wally in Haiti when I was papal nuncio there, a short time, just a few days after the earthquake that devastated Port-au-Prince and the surrounding regions in 2010. So in the midst of the sufferings and emergency of women, mothers, and infants who need emergency help, Dr. Whaley was a soothing and assuring presence. Thank you for what you did. He went back many times after that. Next, we have Ms. Obianuju Ekiocha. She's from Nigeria, and she's the founder of Culture of Life Africa, that focuses on the promotion of life and of the respect for motherhood through respect of the values and cultures of each people or nation. And finally, we will hear from Ms. Maria Madiz, who is the International Director of the Society for the Protection of Unborn Children based in London. She is a native of Estonia. She coordinates for the society the work of a team of bioethical researchers and also manages a coalition of 26 pro-mother, pro-life, pro-health mother, pro-mother's health organizations. So after their interventions, we will have time for your questions until 6 o'clock. So I have the pleasure now to give the floor to Dr. Robert Wally.
Your Excellency, thank you very much. I'm deeply honoured to be part of this panel, and I thank you very much. And I greet everybody here, and I thank you for coming to listen. As you see, the title there has a double meaning. Mothers matter, who on earth cares? As we've heard, motherhood, children are of vital importance to Africa. Insurance policy on their future as families, for their village, for their clan, for their tribe, and even for their countries. For Christians, motherhood is of fundamental importance because a young woman said yes, in our belief, to being the mother of the Son of God. And she nourished and nurtured him for 266 days, presumably, until he was born like all of us. I've been working as an obstetrician since I became a specialist in 1973. I'm pretty ancient. I have, in all those years working in a teaching hospital in Canada, I've never had a mother die under my care as a direct cause, a direct obstetrical cause, hemorrhage, infection, pregnancy-induced hypertension. I've had one or two, maybe three, I can't recall, who've died because they developed an incidental illness. Two of them were cancers, and one was a pulmonary embolus. When I went to Nigeria in 1982, I just couldn't believe what I was seeing. I can recall that one of the first weekends I was there, we had 4 maternal deaths of young mothers on a Saturday. And it creates in you what is normal for anybody, a sense of sadness, deep sadness when you watch a mother die. And then it also created in professionals like myself deep anger and saying, this is nonsense. This is nonsense. Why is it happening here? Who on earth cares? We can talk in the abstract, but we have to deal and talk about one mother at a time. That's how we're going to solve the problem. There's no great blunderbuss therapy here. This is a maternal death. I think she came into a hospital and her hemoglobin was 1 gram. We didn't believe it. We sent it back to the lab and said, it was a little room that could do hemoglobins, and said to do it properly. And they came back and said, reluctantly, 1 gram. And we gave her 2 units of blood, which we got from the local seminary, and we knew it was 1 because it went up to 3. When I came back in the afternoon, she'd gone. And I thought, oh my God, she's died. No, she went home, they said. I said, why'd she go home? She said she felt better. I said, I suppose you would. I suppose you would. But I never saw her again. Now, 80% of all the deliveries take place in the village. Now, when she had a normal delivery, the amount of blood loss, which is not normal, is about a unit, perhaps. About the same as you would give when you went to the blood transfusion service and donated. You donate the blood and you feel a bit dizzy. But for her, with a hemoglobin of 3 grams, and she only had that usual blood loss, it would have been the coup de grace. You never heard from her again. That was a maternal death. Here you can see the whole family gathered round. Yep. Number of wives, number of children, all grieving. Because it's a community, a strong, bonded community. That's why the loss of somebody is so tragic. I saw something else that I'd never seen, and most Western obstetricians, gynecologists would not have ever seen. This is an obstetric fistula. It's been known for about 2,000 years. There's a mummy in the British Museum of Princess Henriette, who died probably at the age of 16 or 17, and you could see what she had as an obstetric fistula. And this is damage to the bladder and the rectum if a mother has obstructed labor. And it's a bit like a cork in a bottle. And the baby's head comes through into the pelvis and gets stuck. The uterus just keeps pushing and pushing and pushing, and the pressure causes necrosis, gangrene really, to the bladder in front and the rectum behind. Relieved, yes, by cesarean section, but there's no access. What usually happens is the uterus ruptures, the baby dies, and sometimes she can be delivered from below, but they may have to end up doing an abdominal procedure, a section, even then later. The women then are incontinent of urine and feces through the vagina. And that's what you see there with a young woman called Comfort. She's holding a bowl between her legs. And this is the small unit we have been helping to develop in eastern Nigeria, where she could get treated because it would need surgery to close those 2 fistulae. They are treated with humiliation. They're humiliated. Simply because we would realize that, don't we? We don't even like our babies to be incontinent. We change them every hour, on the hour. But for them, they're not allowed to the market, to the church, to the community or anything like that because they smell and they're wet. And so it's an awful humiliation. There are about 1 million of them thought to be by the WHO, untreated, maybe 100,000 added every year. This is Maria, who came in. In a sense, it sounds awful to say that she was lucky because she died within a few weeks. She probably had AIDS as well, but as you can see, she had urine burns, she had a fistula, and she had not been helped by anybody, so she has malnutrition. For the comfort at the beginning, it's a living death, really, that just goes on and on and on. I often wonder, when we see all the refugees in the world, you see them crossing through Europe now, you see them wading through rivers and so on, pregnant mothers who deliver on the road. And how many of them are dying, we just don't know. But the media will pick it up and they will show you a happy picture, as you see there. But it belies the truth. Just keep 91% solution in mind. If you look at WHO's figures that I took from 2012, you'll see that the major causes of maternal deaths are hemorrhage, pregnancy-induced hypertension, and then a whole load of other things from HIV, severe anemia, as I just told you, malaria and so on, pulmonary embolus, like we would have obstructed labor. And if you total that, it would mean that 91% of all the deaths are there. 9% will be due to induced or spontaneous abortions. Those 91%, however, die during the third trimester, that's the last 3 months of pregnancy, during labor and delivery, or during the first week, up to 42 days after. So it's obvious what they need. But I think that belays their experience. 80% of the mothers who die are in villages. Can you imagine dying of postpartum hemorrhage in terror? Because when you see a postpartum hemorrhage in our hospitals, it frightens the life out of the obstetrician until you can control it. Obstructed labor goes on and on and on and on in agony. They're alone sometimes, maybe have a relative. That's obstructed labor. But then there are other obstructions. There's obstructed transport. Even if you could overcome that and you could get to, you had no way of getting there. There's no buses, there's no bicycles, there's no taxis, there's nothing. Or there's obstructed decision-making. The mother can't say, I want to go to the hospital. She has to get permission from the husband, the partner. He may not be there. And then when you do get to the facilities, can they cope? The first hospital I went to had one cesarean section kit. And if you had 2 or 3 lined up, you had to decide which one was going first. And then you see that they die from exhaustion and then infections and so on. We have all of those kind of things, but we treat them. So our maternal deaths are minimal. You can cause violence to people by commission. I think we all understand that. By sexual assault, female genital mutilation and so on, abortion, neonatal euthanasia nowadays. But you can also cause violence by omission, culpable negligence, when you didn't provide what was essential to them, which was obstetrical care, or the treatment for those fistulae, or just telling the truth and telling everybody the truth. So we came up with the idea that we had to do something. You know, that anger gets you and you say, look, I've got to do something, not change the world, just to make a bit of a difference somewhere. Just to breathe some life back into obstetrics and maternal health care. So it's not all death and despair. I won't bore you with all of this, just to say, I wondered last year, I think it was, if there'd ever been a Charter of Rights of Mothers. So I Googled it. Yep, there was one, 1932 in the UK. When you read it, it had absolutely no relevance to our experience now. So we came up with this Charter of Rights, and I won't ask you to read anything, but I just look at things like a child is a gift, not an object. That a mother has the right to be respected in every possible way, her dignity, as we've just seen, that every mother shares in that extraordinary dignity that we understand from a religious point of view. Her moral and social and cultural values have to be accepted. She has the right to the treatment and care that everybody gets in the rich world, but is not available in the poorer parts of the world. Comprehensive prenatal care. Prenatal diagnosis. There is no prenatal diagnosis, except what you can find out at the time of prenatal care. Safe, clean, adequate delivery facilities, skilled midwifery specialists like myself. A 91% solution. Enough of talking in the abstract, shedding crocodile tears. Either get on with it. And that's what we've tried to do in Kenya. That's what we started doing back in Nigeria in 1982, and it's now in Kenya. This was the bishop who in desperation sent me an email. I didn't know who he was. We get a lot of funny emails, so I had to check on him to see that he was genuine, and he was. He'd been there 44 years now as bishop. And he said, come and tell me what I should do about the state of health of mothers there. I went and I told him, you've got to do something. And the sad thing about it was that 3 months after we started, he was murdered. And we had to start all over again. So we're in Kenya, bullseye, right in the center. We border on this area, huge area, with Somalia on the right-hand side, Ethiopia at the top, Sudan and Uganda on the left, and Tanzania below. It's under Mount Kenya, in a valley that stretches all the way up to Somalia and to Ethiopia. It's arid. It's very poor. There's a population of 188,000. There's one general hospital. It has one operating room, which is usually down because nobody had bothered to do the maintenance on it. The maternal mortality, excuse the spelling, is officially in the strategic planning document of last year, 2 years ago. They said 560 per 100,000. But the epidemiologist came along and said, I think it's more something like 790 because there's so much underreporting. Nobody really knows because they take place in villages. Only 20% of what you might call a health facility, a little dispensary, provides prenatal care. They have nothing. You can see in the background they though have a lot of plastic that blows around everywhere. It's starting to choke everything in Kenya. And there you deliver. They're the facilities. Usually there is a skin or skins. If she's lucky, she would be a relative, or she was really lucky, she would have a TBA, a local traditional birth attendant. So what we did was not to go and just build a hospital. That's the bottom part. If 80% of the maternal deaths are in the rural areas, that's where you start. You go and find the people. You start, as we did, just talking to people, talking to the elders, talking and say, you don't have to die. It's not inevitable. We got hold of the traditional birth attendants and say, look, you're respected. Everybody knows what you do, and they appreciate what you do. So we started to deal with them. We then, as we've developed this old idea, is to move in a bit more high-tech. We have little motorbike ambulances that allows the midwife who is in one of these parish maternity centres. We only have one. We need at least 3. That one we have now is 225 kilometres from the hospital. I'll show you in a minute. We have an ambulance that's called, it used to be called in the United Kingdom, the Flying Squad. It's an emergency obstetric transport. Then we have the hospital that's able to cope with most everything, which has doctors. We have 2, 3 years out of training. And we have maternity waiting homes. We have the traditional birth attendants that we've trained. What we really wanted to do is not to show them how to do a delivery necessarily now, but to come to the clinic, come to the hospital for delivery. But we wanted to train them to recognize and refer high-risk mothers early. And you say, how can you do that? Well, this is the way we did it. As you know, every mother has a prenatal chart. These ladies are illiterate, uneducated, but they've learned a lot by sheer experience. So we asked them, what are the things you fear most? And there they are on the right-hand side. It's the same list that any physician, any midwife would give you. All the ones I just listed earlier on. And we drew a little cartoon of each. And then there was a checklist. So we said, anybody in this particular pregnancy has any of these things, or in a past pregnancy had any of those things, you send them down to us at the clinic for the midwife to check first, and then on to the hospital if necessary. Then we wanted to learn about other things. We wanted to know something about the public health that was going on. So if there was a maternal death, as you can see up there, you can see both mother and baby alive. Great. If there was a death, well, the baby died, unfortunately. Or the other way around, the mother died, the baby's alive. But that would end up usually in the baby dying. Or they're both dead. And then at the bottom there, we wanted to get some idea of the parity and the gravida of each mother. So while they can't write, they can count because they use money. So we said, okay, tick off on there the number of babies the mother has at home, under fives, who are alive. Make a mark. Underneath that, you'll see the number of dead babies they've had, and you make a mark on the appropriate. And then the number of miscarriages. So what you get here is an idea of what the obstetrical situation is like out there. This takes a lot of doing, takes a lot of staff. I'll make a cry for that later on. But you can see all the hemorrhages up there. You can see one or two other things on the bottom line. On the left-hand side, you can see what is a teenage pregnancy. Now, I wouldn't have recognized that, but that's what they said looked like a teenage pregnancy. In the center, they knew this disease, it's called the shaking disease, convulsions in pregnancy due to hypertension, and big fat legs due to edema. They knew that. And that funny thing that sits at the side of the bed, which the doctor uses, if they've seen that. On the right-hand side, well, we didn't recognize it either. We said, what on earth is a teacher with a crowd of kids from the classroom got to do with it? Well, it's supposed to be grand multiparity, meaning 5 to 7 pregnancies. So the second edition, we had to reduce the number of kids standing alongside. And so the TBAs are there. Maybe WHO and so on have always said we shouldn't be doing that. You can turn your back on the TBAs and you don't see them, but they still may be doing the bad things. So we want to incorporate them into the system, not bring them into the hospital, just bring them into the system, and it works. Here you'll see a proud TBA in the center, having delivered the mother in Manyata. So we started putting a maternity clinic in a place called Murti, 225 miles, right inland, right close to the Somali border. There's only a little building on the right-hand side. It has 4 beds. It has a delivery room, a little lab, and so on. That's it. That's all we could afford. But it's something. And the interesting thing is that communications is very good in Kenya because everybody has a cell phone these days. And they use them. We have the motorcycle ambulance. It works. Ambulance, flying squad, but this is old technology. If you're dealing with this kind of geography, you can't use these anymore. You need a helicopter. When I first went to Canada and Newfoundland, I worked on the Northern Peninsula. In 1963, we had helicopters that we would go and rendezvous in the middle of the ice, in the middle of nowhere, and pick up patients. And they're safely transported. It's better than nothing. There's no other transport. The roads get a little bit tough. And sometimes we have to have some guys to come along too because people come across the border who aren't very nice. Hey, there's a hospital we built. And it looks good, and it's intended to look good. You know, it's a funny thing that happened. People think this is only for the rich people because it looks so good. Well, I said we can make a few holes in the roof if you like and get some rain pouring in if you feel more comfortable. But why shouldn't it be like that? That's the entrance. Why shouldn't there be a delivery room for all mothers? We have them. Why shouldn't they? A little nursery able to look after preemies. And an operating room where you can do a safe, clean cesarean section. And we have to. We take in the emergencies, and you don't mess about. And that's what it's all about. I have to say something at the end here. It's a plea. We've been turned down by the Canadian government for funding 10 times, not on the substance of what we are doing, on the technicality of a proposal which is enormous with umpteen sections on the environment and all the rest of it. And easily, if they don't want to fund us, there you are. And it struck me that we need a sort of a Marshall Plan for mothers. That's what they had in Europe, and it did the job to a certain extent. Everybody says, well, you're crazy. Well, I said there's a precedent for that. There's a precedent because in 1985, the whole world came together and treated the AIDS pandemic. Similarly, just last year, the Ebola pandemic. Why can't we do it with maternal mortality? The first Safe Motherhood conference that put out a goal was in 1985-87 in Nairobi. Since then, not one of the goals has been achieved, not even the Millennium Development Goal. Oh yeah, they've cut the maternal deaths right down from about 500, so they said, down to 200, just under 300,000. 300,000 mothers, and where's the fight from the women's movement? Mothers are women too, right? And so we need lastly, a picture was taken from the London Daily Telegraph. It's a picture of mothers after that terrible tsunami there, 10 years ago at Christmas time. And you can see the agony of the loss of their baby. It's a picture for all mothers who lose their babies at some time during that pregnancy. But there's hope. We can make a difference. And I think this little picture, this little girl up at the top there, I took that picture in the Fistula Hospital in Addis Ababa. She'd come in about 6 weeks before, draining urine, feces, smelling. Nobody would help her. And here she is in the car park sitting there waving. And I asked the audience usually, I said, why do you think she's waving? Well, obviously they say she's had the surgery. I said, yeah, but no. And what they do at that hospital is when that mother leaves, she's given a new dress. And she goes back out through that gate. Nobody will ever know what happened to her. And you've restored her dignity. And that's what this is all about. Restoring the dignity of mothers, dignity to all mothers everywhere. Thank you for having me. That was too long. Oh, no.
Thank you so much, Your Excellency, for hosting this wonderful event and for giving us all the opportunities to come out and share what we have done in the course of our work. Thank you so much, Dr. Wali, for the excellent work that you are doing among the African people. And welcome everybody for being here. Now, I just want to shed some light on this particular problem of maternal deaths and maternal mortality from a cultural perspective and a sociological perspective as well. Especially following what Dr. Wali has said from his vast medical experience, it's only right that we should also see how the Africans view this problem, at least as far as my experience goes. Now, to start off, I must put a disclaimer that Africa is made up of 54 countries. I know this is one of the, criticisms we get speaking about Africa in one brushstroke. Africa is home to more than 1 billion people. We speak almost 3,000 different native languages. And thousands of tribes who have thousands of ethnic groups and clans. There are many creeds, and there are many creeds and religious beliefs professed in Africa. Therefore, there is not just one African culture, because I know that's what people might criticize me for in this talk. But please excuse me, because we still do have a common thread that runs through various African countries, as far as I know. And that is our understanding that human life is precious. Anyone who, even just looking at some of those slides that Dr. Wali had, you can tell that the Africans surely must then appreciate human life, because we do see a lot of deaths, right? There is death everywhere, but we do see a lot of difficulties. And so we consider life precious in most of the African communities. And most people would say that they respect life, human life from conception, right from the womb, in most of the African communities. Also, motherhood is then considered by extension to be precious as well. Motherhood is seen as a blessing rather than a burden. And His Excellency did actually allude to that in his opening statement, that one place in the world, and everybody can attest, many people can attest to this, that one place in the world where motherhood is seen as the real blessing, as the real beautiful thing, is in Africa. Of course, everywhere around the world, but particularly among the Africans. We do also believe that motherhood is a major milestone in the life of the woman. So most cultures and most customs across the continent of Africa actually do have some way of celebrating the birth of a child. So that is quite indicative of the fact that we hold up motherhood as something really beautiful. Now, these are just some mothers that, that I have seen in the course of my work, and I thought, they look so beautiful, and I should share them with you all to see that indeed we do appreciate motherhood. Now, speaking about maternal health in Africa, the reality still remains that we have very high rates of maternal mortality across the continent. There are a lot of inadequacies. We have gaps. We have limitations, especially when it comes to emergency care and blood transfusion services. Years ago, I was working in the health sector in actually a very big hospital in Nigeria, where a lot of my work had to do with providing blood transfusions for people, and I was working in the pathology unit. And I can really attest to what Dr. Wali has spoken about, that we had so many limitations that at points in time when women were bleeding to death following deliveries, that most times we couldn't even do anything. If a woman needed more than maybe 1 or 2 units of blood, we couldn't provide for that. If the woman bled a bit more than anticipated, we couldn't provide for that. So by the time I went out to Europe and I started working in the same capacity, it was a big shock to me that we had all that blood bank, filled to the brim with voluntarily donated blood. So that was a big contrast. And I wondered why at the time. Now, we also have very low percentage of births attended by skilled healthcare professionals, and very low numbers of healthcare workers, physicians, nurses, and midwives per 10,000 people in the population. So maternal health indeed then becomes really very important, that it should be discussed at different platforms. It should be discussed here at the United Nations. And I know it comes up all the time with the Millennium Development Goal, with the Sustainable Development Goals. It is good that it forms the core of what the discussions that are being had. Now, where we differ is how the approach with which a lot of the people in the international community believe that Africans should handle maternal deaths. This is a bit of what the global map looks like. I got this is from World Health Organization, that's from 2015. And anyone can see that very dark patch there. That shows you how much women are dying in childbirth in Africa. So that's definitely, without being contested, we have the highest in the world. Now, here are some of the causes of maternal death as the World Health Organization has put it out. And Dr. Wally has also spoken about this, but these are slightly, they are sort of similar figures, but they're slightly different because this is from a different year. I don't know if that you can see the pie chart there, but these are 4 different parts of the world. There is Africa, there's Asia, there's Latin America, and the developed countries down at the bottom there. And it's from the Lancet. So this is the World Health Organization analysis. Bleeding causes almost 34% of deaths, and then there are other indirect causes. There's sepsis, there is infection, there is hypertensive disorder, HIV/AIDS. So these are all medical causes, obstructed labor. I must say also at this point that one of my cousins, whose wife I was actually close to, she died about 2 years ago giving birth to a baby because she had obstructed labor, which no one could do anything about at the time. So it is also quite personal to me. So these are all different causes. Now, for Africa, even though the global figures are slightly different, the World Health Organization put out in this particular report that for Africa, abortion-related deaths, maternal deaths, is about 3.9%. So that means that more than 96%, I suppose, is caused by all these other different things. That's also another way to look at it. These are the global figures, because I know someone might actually ask, well, a lot of the literature says 8% is caused by abortions, but for Africa it is 3.9%. Now, this is where we differ. The unhelpful solution which is being offered to Africans. When maternal health is being discussed, when maternal mortality is being discussed, these are some of the things, in fact, right at the top of that list, this is what is being pushed in Africa: the legalization of abortion. It is constantly recommended to us. The different countries, many of the African countries, in fact, right now, are battling to keep the laws they have which protect the unborn children. They are fighting so that they don't have to legalize abortion. But through different platforms, a lot of the mostly Western international organizations come to some of our African leaders, some of the parliaments, and suggest to them that strongly abortion has to be legalized. For what reason? So that maternal mortality can be reduced. It then becomes highly controversial for us, because it's diametrically opposed to a lot of our shared values, the way we see life, the way we perceive life, how we understand life as being precious and sacred from the moment of conception. This then clashes with these beliefs and these values. So many African communities now, many African countries are actually torn between their core values, their core beliefs, that abortion is actually a direct attack to human life. This is how many people see it across the different countries in Africa, across the different cultures, that abortion is directly an attack directed against human life at its earliest stage. So we are torn between that And the more developed societies and the more developed countries who are suggesting these things to us strongly, who are also donors to the African countries. So one cannot help but ask, is this another form of colonization? Is Africa going back to a time when we are going to be told what to do in order to save women's lives? The Holy Father, Pope Francis, came to the United Nations last September, and he spoke about what he called the ideological colonization. This was his exact statement. He referred to this as an imposition of anomalous models and lifestyles which are alien to people's identity. These are not my words, these are the words of Pope Francis. And this is exactly where many of the African countries find themselves. And the true fact of it is that there is no real correlation between legal abortion and maternal health. There is rather a real correlation between the standard of our healthcare systems and how women are actually surviving or dying. This is a small comparison. We have Egypt, an African country. Egypt has the lowest maternal mortality rate, one of the lowest maternal mortality rates in Africa. They have 33,000 women dying out of every 100,000, which of course is still unacceptably high. But in Africa, this is actually a really low maternal mortality rate. The World Health Organization back in 2000 released a report that actually rated 191 countries for their healthcare facilities and their healthcare systems. And around the world, Egypt was number 63 out of 191. And for the Africans, that's actually one of the best healthcare systems that we had, according to the World Health Organization. Now, the proportion of births attended by skilled health personnel in Egypt is 79%. The number of healthcare workers is that they have 28 physicians to 10,000 people. They also have 35 nurses to 10,000 people. Mind you, Egypt also has one of the most restrictive abortion laws in Africa. They do not allow abortion under any circumstance, and yet they have the best maternal health to be boasted of in the continent. Now, here is the story of Sierra Leone. Sierra Leone has the highest maternal mortality rate in the world. They have 1,360 women dying out of every 100,000. Their healthcare system also rated 191 out of 191. So that's not a surprise. That's a direct correlation. The proportions of birth attended by professionals is 63%. The number of the healthcare workers is 0.2 physicians to 10,000 people. 2 nurses to 10,000 people. These figures have actually come from an African Union Commission, so they're not my figures. These are figures from 2015. So I take it they are reliable. Recently, we had some incidents happen in Sierra Leone that I found out about, and then I sort of got involved. Last December, the Parliament of Sierra Leone voted to legalize abortion, and they passed this bill. We were told that it passed unanimously, and when I started inquiring about it and asking these questions, why do you have to legalize abortion at this time, Sierra Leone? You have just come out of the Ebola crisis. Most of the citizens that I spoke to, ordinary citizens that I spoke to, who were not part of the parliament, were actually against this abortion bill. But one of the main reasons that the abortion bill went through was because they were promised, they were told by some commissions in the Western world that by legalizing abortion, they were actually going to improve their maternal mortality rate. That is actually deceptive. Abortion, when it's unleashed in Africa, this is what it looks like. We have coerced abortions. We have weakening of marriage and family culture. We have gross medical malpractice. We have abortion-related medical and psychological traumas. We have sexual violence. But the Africans continue to speak out against abortion and against the legalization of abortion. These are the same people from Sierra Leone, from the country where abortion was recently legalized. This was taken last month. And their women were saying no, this particular women's group. That's from Ghana. That's from Cameroon. That's from Nigeria. So across the continent of Africa, people continue to choose life and people continue to insist on abortion still being illegal so that people can protect the unborn. Yeah, in a minute. When given a chance, women always choose life. This was a girl I met in one of Mother Teresa's facilities in Ghana, the one in a brown, the pregnant one. And she had an unplanned pregnancy and she had twins shortly after. This was another one who was raped, Vivian, and she had her baby and she chose life. We will always choose life. These are the unmet needs, the real needs of the African women. We need access to real prenatal health care. We need skilled birth. We need care and support after birth. This is the non-controversial approach that the Africans expect. This is exactly what will be welcomed by the men and women of Africa. Throughout the continent of Africa, no matter the region, no matter the religion, no matter the tribe or ethnic group, we want life for the African people. And the Africans continue to implore the world to come together and continue to persist and insist with us that abortion should not be brought to the African people. Thank you.
Thank you, Your Excellency, Reverend Fathers, ladies and gentlemen. Thank you, Uju and Dr. Wally, for these very truthful accounts on the reality of African life and especially the genuine respect for life and motherhood. I am going to follow up from Uju's presentation by discussing some of the opportunities and obstacles faced by the international community in meeting the true needs of the women in Africa. And my presentation is based on the research of Fiorella Nash of SBUC. Maternal mortality globally is in decline. According to the World Health Organization, the global maternal mortality rates have decreased by 43% over a period of 25 years. However, the Millennium Development Goal of reducing maternal mortality by 75% was not met, and women continue to die mostly preventable or treatable complications in pregnancy and childbirth, as Dr. Wally described. In Britain, maternal mortality began declining from the mid-1930s. It went from being a serious public health problem to a notable public health success story within the space of 15-20 years. The decline continued into the 1960s, a pattern that was repeated in Northern European countries and in the United States. The single biggest factor in the rapid decline in maternal mortality at the time was the introduction of antibiotics, followed by increased use of ergometrin and blood transfusion in the case of hemorrhage, better training and better organization of obstetric care. Advances in maternal healthcare made in developed countries some 80 years ago could, using relatively low-cost interventions, be replicated in other countries. Yet, as Uju very truthfully described, There has been a forceful diversion of resources to the promotion of abortion and birth control in programs that claim to reduce maternal mortality. The Sustainable Development Goal number 3, which is to ensure healthy lives and promote well-being for all at all ages, aim at reducing the global maternal mortality as well as ensuring universal access to sexual and reproductive healthcare services by 2030. The new general comment on sexual and reproductive health issued by the Committee on Economic, Social and Cultural Rights just last week includes the claims that the right to sexual and reproductive health is indivisible from other human rights, that abortion is part of the right to health, and that sexual rights must be enshrined in member states' laws and policies. It is important to note that despite the forceful call for states parties to fulfill their so-called legal obligations as set out in the document, the general comment is not binding. The Committee on Economic, Social and Cultural Rights has no authority to reinterpret the International Covenant on Economic, Social and Cultural Rights and demand state party compliance with issues not included within the text of the covenant, such as suggested sexual right, including abortion. Furthermore, I would like to point out that no human rights treaty recognizes abortion as a human right. The right to life of all members of the human family, regardless of birth or any other status, is a founding principle of the United Nations. Without the right to life, all other rights, including the right to health, become meaningless. The Convention on the Rights of the Child commits states to ensure appropriate prenatal and postnatal health care for mothers and protects the rights of the child before as well as after birth. The authentic rights of mothers and their children are not in conflict. The new general comment on the sexual and reproductive health by CESCR, however, claims that denial of abortion often leads to maternal mortality and morbidity. The committee also claims that this in turn constitutes a violation of the right to life and that lowering rates of maternal mortality requires prevention of unsafe abortions. Many international organizations commonly list so-called unsafe abortion as one of the major causes of maternal death after hemorrhage and sepsis. Not only is this claim highly questionable, attempts to legalize abortion on the grounds that it can prevent maternal death leads to an absurd conclusion that one of the ways to reduce maternal mortality is in fact to eliminate the child, which confers the status of mother on a woman. It is clear from the evidence that maternal mortality was effectively tackled in Britain decades before the legalization of abortion. The fact that international policymakers treat abortion as a maternal health issue for the developing countries and Africa and suggest that legal abortion is necessary to save women's lives is truly a disgrace. As Uju said, pregnancy is not a disease and abortion is not a cure. Abortion does nothing to solve women's problems apart from causing psychological, emotional and physical damage. Abortion, as well as killing babies, sometimes kills women too. The abortion lobby has been successful in creating a false association between safe and legal abortion, with the implication being that if abortion was decriminalized in every country of the world, maternal death as a result of abortion would be virtually eliminated. In reality, the countries with restricted abortion such as Poland, Ireland and Malta have the lowest rates of maternal death. On the other hand, it is estimated that 8% of maternal deaths in developed countries, where abortion is most likely to be legal, are the result of abortion complications. Women in first world countries and women in the third world countries have access to legal abortion. But whereas a woman experiencing abortion complications in Europe or North America can get emergency help within minutes, a woman living in an isolated settlement in Africa cannot do so. Powerful national programs use the unsafe abortion argument as the major plank in promoting and funding abortion around the world. While such programs are usually open about their determination to do so, they are less willing to disclose the proportion of its maternal health funding that is being spent promoting and providing abortions. However, the organizations who benefit from Western governments, such as International Planned Parenthood Federation and Marie Stopes International, reflect the scale that abortion services are promoted through the international development programs funded by taxpayers. In one of their responses to maternal death, Dr. George Mulcair Jones and Robert Scanlon of Maternal Life International wrote, "Vast resources which should have been directed to funding improvements in essential obstetrical care have gone to a different agenda, so-called reproductive health. Rather than focus on the real causes and solutions of maternal mortality, safe motherhood has become entangled within a reproductive rights agenda, which emphasizes access to contraception and promotes abortion." I would add that it seems that it is only in this context that motherhood has deserved any attention in the Sustainable Development Goals, which will direct the financial aid for the developing countries for the next 15 years. Childbirth is rendered safe by a range of entirely ethical solutions: antenatal monitoring, trained midwives, cesarean section, blood transfusion, and with the ability to store blood safely, good sanitation and antibiotics, and adequate transport systems to access life-saving care. There is no reason why there should be this massive ideological battle going over the bodies of women and their babies. The tragedy of maternal mortality in Africa requires a courageous and honest response. Women in developing countries need a good maternity care and access to it, which is not supported by the promotion of abortion by stealth in the name of maternal health. Channeling international efforts to meet the authentic needs of African women is essential to ensure safe outcomes for African mothers and their babies. Thank you.
Thank you, Maria. Thank you, Obianuju, and thank you, Dr. Robert Wali. Now we only have around 10 minutes for your questions. I would like to call on the first three questions that we could have. I guess I would start over here at the back. I think she was the first one to raise her hand. Please make your question short so that we could go around.
First of all, hello, my name is Daniela. First of all, I want to congratulate you because instead of going for a quick solution like abortion and anti-conceptions, you decide to make something beautiful that will help both the mother and the baby. Also, I want to thank you because I know it's not easy what you're doing as a teenager who is concerned about life. I appreciate it. My question is, how many health centers are you planning to build in the first 10 years and how can we help?
I think, yes. Sorry.
Thank you. Thank you very much. Oh, now it works. My name is Mette Gjerskov. I am from the Danish Parliament. I'm a former minister. And first allow me to express my respect for all the work you do for women all over the world and, of course, Africa. I was a bit provoked by the thought of new colonialism. Being from Europe, of course, this hurts me. And so I would like to share a bit because I have been to Africa and I know that there are different countries and I've been to Zimbabwe and Mali and Tunisia and Tanzania and Kenya and Rwanda, a lot of African countries. And I've spoken to a lot of African women. And my lesson learned from being from a colonialistic society is do no harm. Allow people to make their own choices. And when I've been to Africa, I've spoken to a lot of women, and some women want this, and some women want that. But I think we should allow them to decide for themselves. And that includes freely decide over their own body, their own sexuality, when and how many babies they want, if they want contraception, if they want abortion. We don't have to put it on anybody else. So if you want to make sure that you don't start a new colonization, let people make their own choices, decide over their own body. Thank you very much.
We'll take the last one from a man.
Thank you.
We'll hear for
the
Which one? We have three.
Yeah. Oh, great.
Okay, go on.
So I wanted to make a.
Oh, sorry. Go ahead.
Hello, greetings. My name is TJ Williams. I am a candidate for ordination in the American Baptist Church. A member of the Riverside Church here in New York City. My statement is in support of the right for women to choose. It is a spiritual act, because many times through many religious circles, we have taken and have colonized nations to impact whole communities, to use our influence to take away the right for women, to take away the choice, the right of choice.
So, give the panel the right to respond. Thank you.
Which one? Hello. I'm Dr. Raymond Price. I'm representing the Howard Center for Family, but I'm also the director of the Center for Global Surgery at the University of Utah. And I just want to point out that you've done a marvelous job of highlighting the problem and actually identifying the solution. My question will be, how do we encourage people to identify the correct solution moving forward? You identified the problem that in the Millennium Development Goals, we did not achieve that. There are still women dying. And you identified the solution by highlighting the things that have been successful in decreasing that. 50% of those solutions involve surgical care. It involves a health system strengthening measure. And I want to point out that last year in May, 194 nations voted unanimously to pass a resolution indicating the importance of essential and emergency surgical care. And it directs the ministries of health around the world and the World Health Organization to target health system strengthening and putting surgical care into the systems. How are we going to get the Commission on the Status of Women to recognize the solution so we can start saving lives and meet the goals? Thank you.
To answer the question about the number of health centers, I pointed out just what I was speaking about is a question of money. We don't get any funding. What we're suggesting is offering life and hope rather than death and despair. That when you look at the causes of maternal mortality, as I pointed out, 91% of them occur in the last 3 months of pregnancy, during labor and delivery, and afterwards. Abortion and birth control are irrelevant. And so what... So the only solution that's being offered is if a mother wants to stay alive, she's got to kill her baby. That's outrageous. That's outrageous. We don't even do that here anymore. That's all I can say.
Sorry, I'd like to address the lady who had spoken, the Danish lady who had spoken about comparing African women not having the right to choose what to do with her body and it being colonization. It's actually quite amazing how you were able to kind of twist that into shape, to that thought. But I must say this to you. I am from a tribe called the Igbo tribe in Nigeria. If I tried to translate in my native tongue what it means for a woman to choose what to do with her body, I couldn't. Most of the African native languages don't even have a way of phrasing abortion to mean anything good. Now, as communities of people and as societies, where it actually then becomes colonization and neo-colonization, is that people from the Western world come to Africa and try to give us these kinds of language that we could never translate into our native tongue. They tell us that it actually can mean something for a woman to do something with her body, which isn't really morally bad. But anyway, the first thing that we have to think of and remember is that as communities, which was one thing I highlighted right at the beginning, culturally, most of the African communities actually believe, by tradition, by their cultural standards, that abortion is a direct attack on human life. So for anybody to convince a woman that abortion is good, sorry. So I'm sorry. So for anybody to be able to convince any woman in Africa that abortion is actually a good thing and can be a good thing, you first of all have to tell her that what her parents and her grandparents and her ancestors taught her what is actually wrong. You're going to have to tell her that they have always been wrong in their thinking. And that, madam, is colonization.
We are, we are bound by our contract with the conference management of the UN that we must end at 6 o'clock because there is another event. I would like to give the last to Maria the last word among the panelists, and then we will.
I believe that Uju's last word was absolutely splendid. I really don't have anything to add to that. Thank you, Uju. Thank you, Dr. Wally, for everything that you do for mothers in Africa and their children.
Thank you. Thank you very much. We have always believed that, these are very difficult questions and controversial questions, and it is good. I am very glad to have participated in the discussion, and there will be other times. And thank you very much for your active participation, your interest, and unfortunately we are running out of time. So good evening, and again, best wishes to all of you. Thank you.
Very much.